I'm a retina specialist, and in the Bronx, which is one of the areas of New York where diabetes is very prevalent, I specialize in diabetic retinopathy. And my project here at the Academy this year has been a telemedicine program that I started in our institution covering a large patient population of the Bronx who have a high prevalence of diabetes. And what we're trying to do is we're trying to increase access to diagnosis and care of diabetic retinopathy. A lot of these patients have multiple medical problems due to their diabetes, and we find it difficult to get them to come see us for an eye exam, especially when they don't perceive that they're having any changes in their vision due to the diabetes. So what we've done is we've placed cameras to take an image of the back of the eye, of the retina, in their primary care doctors' practices, primary care providers' practices. And what that does is it catches them in we're in a captive place where they have to go to get their medications refilled for their regular checkups. We take an image of their retinas, and then that image gets uploaded to the cloud in a secure server, and then the ophthalmologists from my department interpret the images, and we're able to see which patients are at risk or are starting to develop diabetic retinopathy. We're able to inform their primary care physicians and then inform the patients and get them to come in to see us before the diabetic retinopathy starts to progress and causes real problems. The turnaround time for the photo is about a week. So the images get taken at their primary care doctor's practice, get sent to us, depending on our schedule. The individuals who are interpreting the images run through them online, and then we return the results to the primary care practice. It serves two purposes. One is it allows the patients to get their yearly retinal exam, which is required for comprehensive diabetic care in their primary care setting, and it also allows us to identify those patients that are starting to develop retinopathy. And diabetic retinopathy is a problem that, if caught early, can be significantly addressed, and the impact and the potential loss of sight can be reduced if we're able to identify it early. And this is a way to reach these patients and identify the retinopathy early before it has a chance to develop into something that requires invasive treatment such as surgery. That's the trick. So then what we do, there are two mechanisms. One is that we try to get the primary care practice to either refer them to us, or if the patient has a regular ophthalmologist, to see their regular ophthalmologist. It's not an issue of trying to get them specifically to see us. It's an issue to try to get them to see someone, especially when they have pathology. And we also do outreach to the patients who we know are positive, particularly the ones that have significant findings where there's a significant threat of vision loss that's imminent. We make sure that we reach out to them and get them in. That's the second barrier that we found, is that despite diagnosing patients with diabetic retinopathy, there's still a barrier to getting them in. And that's actually the follow-up study that we're doing, is to try to identify some of the causes of why patients who now know that they have potential for vision loss are still not able to come in and see an ophthalmologist. In general, for many, many years now, the standard of care has been to have a yearly eye exam if you're diabetic. What we found is that in this large patient population that we're analyzing, less than 50% have had their yearly exam. And so even though we're only catching them now, we're getting 100% of what was previously 0%, because we're targeting those patients who hadn't had an exam in the past year. So it's still a really great incremental improvement on the identification of the retinopathy in these patients. The challenge is the cost, not because it's inherently expensive, but because the way the payment structure is set up in the United States now for screening and for telemedicine-based screening, the reimbursements, if we look at the typical CPT reimbursement rate as is provided by CMS, it's a very low reimbursement. So we were luckily able to do this thanks to a grant that we were able to obtain from within our own system, from Research to Prevent Blindness. But in order to make this a national phenomenon, we have to find new ways to create funding for this. This is a great cost saving. So if you can imagine, for health plans and for the general cost of society as a whole, if we're able to reduce the percentage of patients who develop significant retinopathy, which then can be very expensive due to the need for injections of medication or surgery or laser treatment, if we can reach these patients before they develop the problem, it's actually a great cost savings both to insurances, managed care plans or accountable care organizations, and to society as a whole. So it's really, I think we have to try to push the needle towards what we stand to save more than what revenue we can generate by doing this procedure.